Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hey, CEimpact subscribers. Welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard, and I'm super excited about our topic today. We're going to be talking about the new American College of Cardiology, American Heart Association guideline on the management of dyslipidemia. This is a big deal. The guideline retires and replaces the 2018 cholesterol guidelines, and there are a number of practice-changing updates that will impact how we care for patients with dyslipidemia. So we'll focus on those key changes, what the evidence shows, and what we as pharmacists should do differently in practice. And I am thrilled to share that we have a pharmacist expert who was on the peer review committee for these guidelines, Dr. Janelle Ruisinger. So welcome, Janelle. We're so pleased to have your unique expertise for this topic.
Hello, Rachel. Thank you for having me. I'm really happy to be here.
We really appreciate your time carving out of your busy schedule. And I know you've been on the podcast before, but for our listeners who maybe haven't heard from you before, if you could share a little bit about your background, your current role, and why you're interested in this topic outside of that peer review committee that I mentioned.
Sure. So I'm the Associate Dean for Academic Affairs at the University of Kansas School of Pharmacy, and I've been here for 26 years. So part of that role, I'm a clinical professor as well, and so part of my role here at KU is to have a practice site, and so I was in the Atherosclerosis and Lipid Apheresis Center at the University of Kansas Medical Center for probably about 20 to 24 years. That was a physician-run clinic, but there were two pharmacists in that clinic, and we got to practice under protocol with Dr. Patrick Moriarty. And since it was a specialty clinic, our patients were referred to us. So we saw the worst of the worst when it came to dyslipidemia, when it came to tolerating medications, when it came to family history and events and things like that. So that's where that passion comes from and still lives on.
Absolutely. And definitely a unique patient population. So you've probably, as you said, seen some interesting cases that would help shape your understanding of this topic for sure.
Definitely. It was a lot of fun, challenging, but yes, a lot of fun.
Yeah, excellent. Well, let's just dive right in because I think we have a lot of ground to cover. And I do want to start with just getting us on the same page around the 2018 guidelines. I mentioned those are being retired and replaced with this new set of guidelines. And think about where we were and then where we're going. So if you could give a brief overview of where we were, and then we'll get into where we're going with these new changes.
Sure. So with the 2018 guidelines, we had thresholds instead of lipid goals. And so we were looking to lower the LDL 30% or 50%, depending on the risk. We were using moderate intensity, high intensity statins, kind of based on how much we needed to lower that LDL. So that is one thing that'll be different that we can talk about here. The other thing is when we were using our risk calculator, the risk calculator was for those who were 40 to 75 years old, and our new risk calculator gets us down to patients who are 30 up all the way up to 79. So we broadened that age group as well. And then we also reduced the level where we consider risk. And so before it was 5% or higher, now it's 3% or higher. And so a few of the major changes there as well. We talk a little bit more about the nonstatin therapies that are options for our patients, and the strong data that's behind putting those with the statins are a few of the changes. You know, some things still stayed the same. The lifestyle modifications, right, are still key, regardless of whether you're on a medication or not. Statins are still kind of the basis, the starting point for the lipid lowering. So some really great changes, and then a few things that stayed the same.
Yeah. Well, I won't keep us in suspense anymore, and we could get right into those changes. But I do remember when those 2018 guidelines came out, and it was a big shift in thinking then because we had moved from LDL goals to using target statin doses, and that was a big change. And now we're sort of, the pendulum is going back in the other direction, and as you alluded to. So let's go ahead and get right into those changes, and let's start with maybe those LDL targets, as you mentioned, because I do think that's a pretty significant change.
Sure, absolutely. So we come back to our LDL targets. And so for our patients who are considered very high risk, their LDL target now is less than 55 milligrams per deciliter. So we did not even see that before, right? When we had our targets, it was less than 70.
Mm-hmm.
But we know
Mm-hmm.
now that lower is better. And so they brought the level down a little bit. Now, and that follows the European guidelines because the European guidelines has had their for their high risk patients the LDL less than 55 for a number of years now, and so
Okay.
that
Okay.
is one of the big changes. But it's also exciting. And then the other one, we still have our LDL goal less than 70 and less than 100 for those other patients based on their risk stratification.
So just to clarify, the LDL less than 55 is for those secondary prevention patients. So patients
Mhm.
who have had a heart attack or stroke cardiovascular event, who are in that highest risk category is the less than 55 target for them. Can
Mhm.
you speak a little bit more about when the less than 100, less than 70 cutoff applies?
Sure, sure. So a couple of places where that is going to come into play is if you're looking at calcium scoring, and so they stratify that based on that particular score. And then also when you're looking at doing that prevent calculation and how if they're coming out as low risk, moderate risk, high risk based on their percentage, are a couple
Okay.
areas where those will come into play.
Okay, so let's back up a step, I think. And you mentioned the prevent cardiovascular risk calculator because that's a change too. And so let's talk about that a little bit more, how that compares to what we were using and why that's now the recommended calculator and key considerations with using it.
Sure, sure. And so before we did have the ACC AHA risk calculator, and again, it was from age 40 to 79,
Mm-hmm.
but we know that patients younger than that can have events and can be at risk. And so this new prevent calculator actually will assess risk from 30, like I mentioned earlier, all the way up to age 79. And why that's important is because we know that cardiovascular disease, ASCVD, doesn't develop overnight, right? It's a long process, but it's related to exposure to the LDL, right? Exposure over time, LDL and other parts of the cholesterol. So if we can get that lower sooner, we are going to prevent the patients, hopefully prevent events over time. And so being more aggressive sooner is kind of where that prevent calculator is fitting in opposed to our previous calculator. And then again, as we mentioned, we're now looking at 3% and higher risk opposed to the 5% and higher risk. And again, that's because you want to reduce that exposure sooner to hopefully
Mm-hmm.
prevent events down the road.
Would it be fair to say that the general takeaway or sort of message from the guidelines is lower is better for longer? Like over the course of your life, lower is better. And that's why, as you say, there's this focus or attention ability to identify patients as young as 30 with the risk calculator and treating at lower thresholds, treating to lower targets. Is that a fair sort of summary?
Yes, that's a great summary. Yep.
Okay. Okay.
Lower, longer is what we're
Yeah.
essentially looking for. And again, that's simply to reduce those events down the road.
Hmm.
5, 10,
Hmm.
50, people are living longer, and so we want to reduce those events over time.
And what about the data, the evidence to support some of these changes? Has there been new sort of obviously it's been 10-ish, 8 to 10 years since the last guidelines were published. So what evidence has come out since then that has led to that lower is better for longer
Sure,
thought?
sure. Some of it I think is when you're looking at some of these new therapies that have come out in the past few years. So, for example, the PCSK9 inhibitors. I know they were out with the, other guidelines, but there's a lot of data out there now with some of these add-on therapies on how well the
Hmm.
patients are doing with that very low LDL. And so, yes, and that's another thing that I love about these guidelines is they are evidence-based and they have been in the past, but we've got the strong evidence to support those recommendations that, yes, the lower we get that cholesterol, the better outcomes we tend to have with the patients.
Yeah, and I'm glad you brought up the PCSK9 inhibitors because that's I think where we've seen this pretty dramatic lowering of LDL in some cases. And so it makes sense, right? That once we're seeing that data with, especially longer term data with those drugs, we are able to see this lower is better. And also that there's less concern about going too low. Like I think that was a concern in the past, is how low is too low? Is that something we need to be concerned about? But again, with these PCSK9 inhibitors like alirocumab and evolocumab, we have more data that's maybe reassuring about that too. Maybe you could speak to
Yes.
that a little bit.
Definitely, definitely. And so, right, there were concerns that, you could go too low and cause problems. And we have not seen that in the, randomized controlled trials that are out there. And then we have a lot of data from patients now that they're out there, right? The drugs are out there and they've been used for quite a while. We aren't seeing this surge in events from related to cholesterol that's too low.
And seeing benefit on the other hand, seeing
Absolutely.
benefit, and that's
Yes.
driving some of these changes that we're seeing in the guidelines. Okay.
Right. Yep.
Okay. That's good clarification. And so going back to that prevent calculator, and there are a couple of prevent calculators. So for people who are pharmacists who are going in and using this maybe for the first time, can you speak a little bit more about which calculator we're using? What are the variables that go into it? What you do with the results? How does that look if you were actually wanting to use this in
Sure.
practice?
Sure. And that's a good point too, using it in practice. It requires a couple of lipid levels, right? It requires the systolic blood pressure and their whether they have, diabetes and smoking and hypertension and things like that. And so a pharmacist, if you're thinking about being in that community setting or even in a busy clinic, you could certainly use a technician to input that information. And then the pharmacist can be the one to have that discussion with the patient and that clinical decision making. And so I want to touch on that just a little bit because I know that for some pharmacists, when you're in a busy pharmacy, you're thinking, how in the world am I going to have time to do
Yep.
all this? And so if you do have some of those readings, then you can certainly let a pharmacy student could check the blood pressure and then also put that information into the calculator for sure. And so I know the one that I went and used here not too long ago was just the one that was actually, I think there was a link to it in the guidelines, or I Googled it and there was it came up to it. And so that's the one I
Yeah.
used. And it feels very similar to the other risk calculator in the way it looks and then the information that you're putting in and things like that. But then again, it talks a little bit about that less than or that higher than 3%, and does the risk stratification from that point. And then again, you, in the old one, if you would put in someone who was less than 40, it wouldn't give you
Right.
the information. And now when I was playing around with it, you put in someone who's 30, who's 31, 35, adjust the numbers a little bit, kind of see how that would impact if you're just wanting to be familiar with it and what the results might look like. That's some pieces of that one that are going to be a little bit
Yeah.
different.
Yeah. So I love a couple points that you brought up there, that it's accessible, it's easy to use. So like you say, prevent risk calculator, and there's the prevent CVD risk calculator, which we talked about actually on a prior podcast, which is in the hypertension guidelines, and using that in terms of assessing hypertensive risk. And then prevent ASCVD, which is the one in these guidelines. And then I think there's also prevent heart failure calculator too. So you just have to look at that when you're selecting, making sure you're selecting the right guideline in terms of discussing these risks with patients. But like you say, it's very easy. And I did it for myself, just to play with it and see how it looks and what results you get. And you get the 10-year and 30-year cardiovascular risk. And that's what you use, as you said, to help then take the next step around. Okay, is it low, less than 3%, or borderline 3 to 5%, or higher, and then make your treatment decisions from there. So I'd encourage our listeners to just play with it themselves and see, how it looks. And then, as you say, have a technician, have an intern use that, and they can sort of pull it up, get it ready, and you have that cardiovascular risk percent for the discussion with the patient. Great point. And so once we have those results, what is your sort of next step in terms of decision making, and what would you talk to a patient about? And actually, just to clarify too, that calculator is for primary prevention. So again, we're not talking about patients who've had a cardiovascular event. We're talking about those who've not, and assessing whether they need a statin or other lipid lowering therapy.
Right.
Okay.
Right. Yeah. And so if it's less than 3%, you talk to them about maintaining a healthy lifestyle and kind of, keeping an eye on it and plugging along. If it's that 3 to 5%, you're kind of looking at some other pieces that could play in and what other risk stratification can you do? Maybe it's time to look at an ApoB level or maybe, even a calcium score if there are some other things that would point to it. And then as they move up in the risk stratification, then it is time to start talking about starting that statin therapy and trying
Mm-hmm.
to get that LDL down again, along with the lifestyle modifications and things like that. So I think where pharmacists may start getting some questions and play a really key role again is in some of those younger patients that are now going to either qualify for a statin
Mm-hmm.
or they're going to be on the border and helping them understand that less is more. And right, so you want
Mm-hmm.
it
Mm-hmm.
lower for
Mm-hmm.
longer, like we said earlier. And I recognize that nobody walks in and says, "Man, I can't wait to start a new medication." Right? That's not what patients do.
No, no.
And so having that conversation, addressing any concerns, addressing any misinformation, because man, they go on the internet and they can find all kinds of misinformation. And so, or even, helping correct that, but also guiding them to useful reputable websites that are patient friendly. And so thinking about the American Heart Association and the great information they have there that, there's the part that's for patients, there's the part that's for healthcare
Mm-hmm.
professionals, and pointing them to some of those reputable sites, or even having handouts at the pharmacy if you have a population that, a lot of people that may qualify that for therapy or to be addressing those issues, to help guide them and point them in a direction where they can get some strong, reputable, good information.
Mm-hmm. That is so challenging. And like you say, because more people will qualify, I think a lot of the concerns that we've heard for years about statins in terms of muscle aches and even dementia, some of these concerns, diabetes, all of these issues, I think are going to sort of crop up probably again in conversation. So, how would you help navigate those discussions for pharmacists who are talking with patients who really may benefit from a statin for the reasons you said and are now qualifying for a statin? How do you have those discussions?
Sure, sure. Um, y- yeah, and it's going to take multiple discussions, right? There isn't going to be one answer that, all of a sudden they're going to, agree to it. They're going to be hesitant and have their beliefs, and so you just have to kind of keep at it. But letting patients know that the percent of patients that get the muscle aches and pains from statins is pretty low. And if they do get it, you can always reduce the dose. We can try a different statin. We can do alternative dosing. They can stop it and then see if the muscle aches improve. Because the other thing we see, right, when someone learns that their cholesterol is high, they tend to maybe start an exercise regimen or,
Absolutely.
right?
Mm-hmm.
And so
Mm-hmm.
if you're doing that at the same time, then
Mm-hmm.
you may blame the muscle aches and pains on the statin, whereas in fact it's because you haven't really exercised much for a long time. The diabetes one came up a lot in our clinic, early on. It seems to have kind of faded a little bit, but again, patients who don't want to take a statin will kind of latch on to that.
Mm-hmm. Mm-hmm.
And certainly letting them know that the benefit of a statin outweighs the risk of the diabetes, and it's not. We usually see those blood sugars go up a little bit in patients who already have risk factors for diabetes. It's not
Mm-hmm.
someone who it's usually those that have their blood sugars a little bit high already or already have that, metabolic syndrome going on
Mm-hmm.
and things like that. And again, the benefits of that statin will outweigh the risk of that for sure.
And to tack on to that concept too, I'm glad you called out some of those other risk factors. And there are, I think, considerations in the guideline around some of these other risk enhancing factors. So even outside of the what you plug into the calculator, like metabolic syndrome, I think is one of them.
Hmm.
Other risk enhancing factors that might contribute to a person's overall cardiovascular risk. But with diabetes specifically, the guidelines do reiterate the importance of a statin for patients with diabetes. That is a population that is indicated to receive statins, right?
Absolutely. Yep.
So,
Yeah.
so even if there's concern about that, as you said, it's patients who may have already been at risk anyway. Maybe it tipped them over the threshold, and even so, if you have diabetes, a statin is indicated. So,
Yep.
good
Absolutely.
reminder and discussion point there too.
Mhm.
So we've talked a lot about statins. Let's thinking about what in since the prior goal was knowing you'd have to use a high or moderate intensity statin for certain patients. How does that come into play now with these LDL goals? And again, I know it depends on the patient's specific risk that we're talking about, but where do high and moderate intensity statins sort of fit in here?
Sure, sure. So let's kind of think about that getting a lot of our patients to less than 55 or less than 70. We can kind of start there. Even a high intensity statin. So when you're thinking of your top dose of rosuvastatin, your top dose of atorvastatin, you're probably not going to get everyone down to less than 55. And so we're probably going to need add-on therapy, whether that's ezetimibe, whether that's a PCSK9 inhibitor, right? Maybe both. We had patients in our clinic that were actually on all three. But also thinking about the highest tolerated dose of statin. There's some talk in the guidelines about that as well, right? And so if a patient starts rosuvastatin 40, gets the muscle aches and pains, really struggling with it, maybe back them down to 20, it's going to pull them back from their goal a little bit, but we have a whole arsenal of other
Mm,
medications that we can add on to get them down to that goal. And sometimes that takes a little bit of convincing and discussion as well. But hopefully the patient, we can motivate the patient to want to get their cholesterol down. And then, any more, the statins, we can do a statin that they can take any time of the day, right? The high intensity ones, we can certainly
hmm
do that. Ezetimibe, you can take any time of the day. The PCSK9 inhibitors are not a daily dosing, even though it's an
hmm
injection. So I think we are also coming out as you add on medications, regimens that are still manageable for the patients to get that LDL down to where it needs to be. If you're thinking of a goal of less than 100, hopefully we can do that with a high intensity statin. But again, if they can't tolerate it, we may need to add a medication, and it all depends on where they're starting, what their starting level is also.
Right,
Um,
of course.
I was going to say, and I think something else really important where pharmacists can have a huge impact is for the adherence of these medications. Um, you don't feel any different whether your cholesterol is high or low a lot of times. And
hmm
in fact, you may in your mind feel a little bit worse if you're on a
hmm
statin, whether that's real or perceived. And pharmacists are going to be huge in following up and asking the patient, looks like you're needing a refill on your statin. How are you doing on that? And talking to them about it, because it's astonishing the number of patients who receives prescriptions but don't fill them, or they'll fill them and then never take them and never get a refill. So that's another huge place where pharmacists can make a big impact.
Absolutely. So many great points there. The idea of adherence, and not only the adherence once a patient starts and maybe they get their first month and then they have some issues, and whatever the issue might be, it's worth, if they're not getting that refill, evaluating, having that open discussion, having the safe space for them to feel like they can share any concerns that they might be having, and working through that. Because as you said, there's a whole menu of options available. There's alternative statins that you can try. There's lowering the dose options. So there's lots of different ways that we can work together to help them get to a lipid lowering regimen that will work for them. But also that primary non-adherence issue, where a patient who doesn't come in for the prescription in the first place, and before returning those back to stock, perhaps recognizing, oh, this is a new statin for this patient. As you said, a lot more people are going to qualify. So these might be
Hmm.
patients who maybe there was something lost in communication with their provider, and following up to say, hey, did you know you have this statin? You never picked it up. Just wanted to talk through what you and your physician talked about. So
Hmm.
yeah, I think that's a really important point to bring up. And just again, staying alert for some of those gaps, and also then working with the patient to talk through any concerns they have and helping them stay adherent with it. Uh, and again, going back to the menu of options with the statins, and then as you said, ezetimibe, the PCSK9 inhibitors, and helping patients understand that even though the goals are lower than they were before, there are more options to help get you to those targets. So it's not out of reach. It's just something we might need to work through. one class or one drug that's relatively newer is bempedoic acid, and I think that one is less familiar maybe to some of us because it's newer. And so, could you talk a little bit about the role of that drug specifically, just how it fits in compared to ezetimibe and the PCSK9s?
Sure, sure. It's a stepwise approach, right? And so you
Okay,
kind of have to just find the right cocktail for the right patient. And as much as we just have to also acknowledge that insurance may have play a role in
absolutely.
that also,
Hmm.
right? And so
Hmm.
I think the nice step a lot of times can be a statin and ezetimibe because they're both generic. And so
Yeah.
hopefully affordable, easy accessible. You get into the PCSK9 inhibitors, not generic, can be quite expensive. And then the same with bempedoic acid, not generic, can be quite expensive.
Hmm.
The
Hmm.
other thing to think about is where you are. So after you hit the statin and the ezetimibe, do I need another 30-40%, you may need to hit a PCSK9 inhibitor
Hmm.
opposed to bempedoic acid, which isn't going to give you quite as much as that. I mean, it'll give you some, but you're not going to get the bang that you
Yeah.
are like you will with the PCSK9 inhibitors. And then the other thing for a practitioner and a pharmacist, if a patient is just like, I cannot give myself the injection, I don't have anyone that can do it, I'm terrified of needles, I'm not doing that, then that's kind of answered there for us, right? And maybe
Hmm.
bempedoic acid is a better approach than the PCSK9 inhibitor, and we can breach that with the or go that way with the patient if we need to, if we still can't get them to goal on that triple therapy. So, like the physician used to say in our clinic, it's just a matter of finding the right cocktail for each individual patient. And sometimes it's hard to get the patients to stay patient with us because you don't want to throw it
Hmm.
all on at the same time, right? And that's going to be even, I think, a little bit more of a challenge with these guidelines and these lower LDL goals for some of the patients because you want to do it in a stepwise approach. You want to make sure they tolerate the medications before you add something else on, and so it'll take a little bit, but we will be able to get there if they'll stay with us for sure.
Yeah, yeah, and thank you for providing that context because, as you say, there's a lot of it's nice to have options because, as you say, cost considerations can be an issue, injection versus oral, the LDL lowering you're looking for, patient specific considerations like comorbidities. There's all sorts of those factors that come into play. So yeah, very nice to have options, and good reminder that we'll need to tailor depending on all
Hmm.
of those factors for the patient. You know, those non-statins that sort of fell out of favor with the last guidelines, but what about things like fibrates or bile acid sequestrant, some of those older drugs? Like, if we're thinking about cost, what is the role of some of those other agents?
Sure, sure. I'm glad you brought that up because I did want to mention that it's interesting in these guidelines, or not interesting, but I think very appropriate in these guidelines. Gemfibrozil is absolutely not recommended with a statin. It's
Hmm.
contraindicated, so that's another place where pharmacists can really
Hmm.
make an impact. And occasionally you still see Gemfibrozil, or we did patients coming in clinic, and that was one of the first things we did was, switch that over. And so, um, something where pharmacists can be definitely screening for that if someone is starting a statin. The fibric acid derivatives, the fibrates, we're looking at fenofibrate. If they have really high triglycerides, again, the statins are still first line for those patients, even in high triglycerides. If we're at triglycerides above 1,000, then we're worried about pancreatitis and need to kind of look at the fibrates, at the prescription fish oil, and things like that to help bring that down. And so that's where those are. When you're thinking about, they do mention the bile acid sequestrants in the guidelines. They're just challenging. You
Yeah.
have to separate them from the other medications, right? Because they can bind. If you are using the powder, it's like drinking sand, and some
Hmm.
patients don't like that. The pills, if you're taking the pills, they're very large, and it can be difficult. And then the amount of LDL lowering that you get a lot of times isn't maybe what it can be with some of the other agents, or it simply isn't what it is with some of the other agents. So it often feels like a lot of effort for
Yeah. Yeah.
not, a lot. So then you think about, I can take this teeny tiny ezetimibe
Right.
opposed to
Right.
drinking this
Right.
powder. Niacin completely out of favor, does not have a place in lipid lowering. And then along with that, I'm just going to touch real quick on the supplements because
Mm.
the guidelines specifically call out supplements and say they are not to be used for lipid lowering. So another great place where pharmacists can kind of catch that if someone's looking at the red yeast rice, if they're looking at the supplement fish oil section, if they're looking at ginger, cinnamon, all of those that people read about or hear about on the internet or on TV or whatever it is, those are not to be used. And we're sticking with the prescription products that have the strong data behind them, the good manufacturing practices, right? The regulations
Yep.
and things like that. So.
Yep. Yep. Have been studied and found to be effective and safe versus
Hmm.
not necessarily knowing what you're getting in a supplement product. And also not introducing potentially unknown drug interactions or other issues with if somebody is taking this over the counter, there's all sorts of issues that crop up. So I'm glad that you brought that up, and something that absolutely pharmacists can be screening for, asking about as part of updating profiles or doing med reviews and evaluating that and helping to steer patients towards those proven therapies instead.
Hmm.
Absolutely. And again, knowing that we have options now to
Hmm.
support LDL lowering in an effective and safe way, that it's a great way for us to redirect there.
Hmm.
Um, you mentioned fish oil for triglycerides, and I'm glad you touched on the triglycerides because that is always a sort of conundrum too for patients with high triglycerides, but maybe the LDL is in concern, and as you say, reinforcing statins are still the first line for that as well, along with lifestyle changes too. So again, statins are your go-to there as well.
Hmm. Yep, they certainly are.
Okay.
Yeah.
Okay. Great. So thinking about, you mentioned a couple of those other markers like ApoB and lipoprotein A. And so maybe you could speak a little bit more about those. I think those are maybe less familiar to us as pharmacists. And I know they're a pretty significant focus of the changes with the guidelines. So could you speak
Hmm.
a little bit about some of those updates?
Yeah, that is another thing that I'm really excited about these guidelines, and something again that has been in the European guidelines for a number of years. But lipoprotein A is another component of the cholesterol. It can cause, cardiovascular disease similar to LDL. But the interesting thing about that particular molecule is that it's hereditary, it's inherited. So the level that you have is what you're going to have for life. And so
Hmm.
some patients have very high levels. We would in our clinic, we would look at it in patients who had had events when they were young. If there was a family history, it got to a point where we pretty much started screening it in everyone. Um, and the guidelines now recommend for the first time a one time check for everyone. And then what do you do then if it's high? You then are more aggressive with the LDL lowering because the catch with that is at this time aren't any agents that lower lipoprotein A lot. The
Okay.
PCSK9s can lower it about 25%, kind of depends. But we can get a little bit of lowering there, but there isn't anything that targets the lipoprotein A. But fingers crossed for the next set of guidelines because we've got some things in the pipeline that we're really excited about. Um,
Okay.
but again, having that knowledge that I'm going to be aggressive with my other risk factors, my other, components of
Mm-hmm.
my cholesterol, so that I can kind of mitigate any issue that lipoprotein A may cause. So that one's really exciting. The other one that you had mentioned is the apolipoprotein B. So this is another component of the cholesterol, again, very atherogenic, and it is more, I saw it described the other day kind of in a cool way. So it said if you think of a freeway, LDL are the people and the ApoB are the cars. And if you reduce the number of people per car,
Mm.
but you still have all the cars on the freeway, it doesn't reduce the congestion,
Ah,
right?
okay.
Yeah,
Yeah.
kind of an interesting way to think about it. And
Yeah.
so for a patient who may have got to their LDL goal, but maybe they're still having events, you could look at that lipoprotein B, and then that would tell us, okay, we need to be even more aggressive with that LDL. Or for patients with that metabolic syndrome, with diabetes, high triglycerides, those are some of our patients that would be good candidates for checking that apolipoprotein B. Also, in some patients who maybe who do not have events, do not have diabetes, but you did that prevent risk calculator, and maybe it's
Mm-hmm.
kind of unsure whether they should
Mm-hmm.
start a statin. Checking that ApoB is going to maybe give us more information where we could go one way or the other on that.
Mm-hmm.
So pharmacists may see more of those results coming in if they do have patients that bring in their lipid results, or they may start getting some questions about those
Mm-hmm.
particular products, or why my statin is being increased, or I'm getting another product added on. It may be because their lipoprotein A or their ApoB is elevated. So that's a really exciting piece of the statins, because you're looking at dyslipidemia as a whole and not simply hypercholesterolemia, which is a nice touch, and I think is going to help us even capture more patients and hopefully continue to reduce events.
Mm-hmm. Yeah, and I did not realize that lipoprotein A is a you're born with it. It sounds like you have
Hmm.
one you're reading, and that's why the one time
Hmm.
check of it is sufficient for a lifetime, and you get that really valuable information. So that does seem like a pretty significant change, and something that more patients will
Hmm.
be getting that data, and helping that shape their risk assessment. And then the ApoB, as you said, also another sort of risk enhancer that can help to guide that. The other thing was the coronary artery calcium. You mentioned that earlier
Yep.
too. Let us know where does that fit into, and what does that suggest?
Sure, sure. And so when you're thinking again about identifying risk, so someone who's already had an event, probably not going to do it, right?
Yep.
Someone
Yep.
diabetes, probably not going to do it. They're already considered on that high risk. So it's those where we're just unsure, right?
Yeah.
They
Yeah.
might, or maybe they're given some pushback. They don't really want to start it. If
Yeah.
it's a
Yeah.
younger patient, doing a calcium score is going to give you some nice information and help further assess their risk. And then again,
Okay.
based on what that score is, then you stratify their LDL goal, and how much we need to get that down. So
Okay.
something that we may be seeing a little bit more frequently as well.
Yeah. 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 So again, I think it's great that you mentioned these, because as you say, patients may be having some of these values available to them and asking, what does this mean? How does it change the recommendation around what I should be taking? Do I need a statin? And if you have some of that data, that is a really powerful tool, I think, to help you with some of those discussions.
Hmm. Definitely.
Yeah.
The arsenal of things that we have to not only assess our patients and kind of figure out where they need to be, and then the tools that we've got to help them get to their goals is just so exciting, and has expanded so much even since the 2018 guidelines.
Yeah.
It's really
Yeah.
nice.
And that's why it makes sense that we have this lower for longer is better, and that you can reach that again with some of the data and the tools that we have, as you say it. So that's great. So thinking about these updated guidelines, if a pharmacist just sort of needs to be thinking about, what do I need to what is going to be the question I'm going to get tomorrow, or what do I need to be most prepared about, or is there anything else that we've missed that you want to be sure we address in terms of these changes, or what patients might be asking about?
Um, I One thing I will say is, if someone decides to pull up the guidelines, they're 90 plus pages. And so honestly, right, we're not going to, let's, be realistic here. And but there is a nice, at the beginning, and there's multiple places where are there, the top takeaways from the
Mm-hmm.
new
Mm-hmm.
guidelines. And so
Mm-hmm.
being familiar with that, I think will help a lot of answer a lot of the questions. And if there's something in those top 10 where you're like, I'm not quite sure what that means, or I need to learn a little bit more about that, then you can dig into that section of
Mm-hmm.
those
Mm-hmm.
guidelines. But I get concerned because I fear that people are going to open up those guidelines and see how many pages they are, and just put it to the
Yeah.
side, and I'll worry about that later. But I think there are some things out there. There have been some nice, I've even seen a couple of nice YouTube videos that were only about 5 minutes, that this CE like this can certainly help.
Mm-hmm. Mm-hmm.
But look at those key takeaways. And then there have been some documents that compare the
Mm-hmm.
2018 to the 2026. A couple of those are pretty long too, but just glancing through those to see some of the
Mm-hmm.
differences could be helpful as well.
Yeah, I'm really glad you brought that up, because it is a long set of guidelines, but like you say, it's even called, I think, the top take home messages, top 10 take home messages. So if you just want the cheat sheet, that's there. And then
Hmm.
also I found the algorithms and the flow charts and some of the
Hmm.
graphics in the guidelines very helpful. So if you really just want a quick snapshot of okay, if a patient's prevent ASCVD score is this is what you do next. And it really does walk you through that patient care process, I think, really well. And also, I saw a graphic about this concept of through the lifetime. So screening younger patients too. So children and adolescents, I think, are part of the screening where they weren't before.
Yep.
Yeah. And then, walking through and considering statins in the younger patients as well. So just some really nice graphics and algorithms to help make it more digestible too. So if you're, just your Control F for figure, you can get through it more quickly that way too. So I'm glad you brought that up don't get scared. Just focus on, if you need to just the bite-sized chunks, get to it that way. Yeah. Great point.
And I will say that was very purposeful when in the review that was talked about a couple times where we had to have those key takeaways for people. We wanted to make sure that the flow charts were easy to read and were not confusing. And so that those will continue to be, it's always a work in progress, but that was a very mindful, intentional thing that they did for these. So again, hoping they're not useful, right? If people aren't going to look at them or don't understand them. So we really wanted to make it user friendly as much as we could.
That's great inside scoop that you just shared, Janelle, from your peer review expertise there is sharing, helping to make sure that the guidelines are usable and actually applied in practice. Because I think that's the other thing is often it takes time to catch up with the guidelines. And so that, as you say, just get educating and making it easy to use. That's what we're all trying to go for here and get those messages out. So it sounds like we've covered a lot of ground in terms of new, the new risk calculator, the younger considerations and sort of that lifetime consideration of risk and how that leads to lower is better for longer. And, as you talked about the role of statins and non-statins and clarifying that. So I just think there's a lot of opportunities for pharmacists to make patients aware of some of these changes, discuss the impact of these, help with adherence, and really individualize care based on some of those factors you talked about. So great summary. And we covered a lot of ground. It is our Game Changers clinical update podcast. And so we always wrap up with, what is the game changer? What do you think is the one thing that our listeners should walk away with from this guideline?
Sure. We know from the evidence that, like you said, less for longer is the key to this. And we can't get the LDL down, we can't get the cholesterol down unless the patients are taking the medications. And so I feel like the pharmacists are the real game changers in helping implement and get patients on board with the guidelines and where they need to be in their therapy and in their lipid levels.
Yeah. Great bottom line there. I love it. And Janelle, I just want to thank you so much for your time and expertise on this. It was really enlightening. And as I say, a lot to learn, but little by little, we'll incorporate it in our practice and really make a positive difference to patients' lives. So excellent. Thank you so much for your time.
Thank you. I've really enjoyed it. Thank you for having me.
Excellent. Well, listeners, I know we talked about a lot of great practical tips today, and these will all be summarized in the practice resource that goes along with this podcast on the CEimpact website. So I would just encourage you to check that out because it'll help take away some of the talking points that we had and really give you a tool that you could have by your side in practice. And be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.